Welcome to Neurobrief, where we provide concise, high-yield neurology content. Today's video focuses on acute ischemic stroke, a critical emergency that requires prompt recognition and management. With ischemic strokes comprising 87% of all strokes, fine-tuning our approach to diagnosis and treatment remains crucial for optimizing patient outcomes. Acute ischemic stroke typically manifests with sudden onset neurological deficits. While the classic presentation includes unilateral weakness, facial droop, and aphasia, we must remain vigilant for more subtle presentations. Time remains a critical factor, and rapid differentiation from TIA, intracerebral hemorrhage, and stroke mimics like migraine with aura or hypoglycemia is essential. A rapid, accurate diagnostic workup is key. Start with a non-contrast CT to exclude hemorrhage. An MRI with diffusion-weighted imaging or DWI remains the gold standard for detecting early ischemic changes. The NIH stroke scale should be performed on every stroke patient, not just as a severity metric, but as a guide for treatment decisions. Even in cases with a low NIH stroke scale, patients presenting with disabling symptoms like aphasia or hemiparesis should be considered for thrombolysis. In the inpatient setting, a comprehensive workup is crucial. This includes MRI brain without contrast, a 2D echocardiogram with bubble study, A1C, and LDL targets below 70. Continuous telemetry monitoring is essential to rule out arrhythmias like atrial fibrillation. Evaluation by speech therapy, physical therapy, and occupational therapy is imperative for a holistic recovery plan. Determining the stroke etiology is a critical step as well, guided by the TOAST criteria, which classify strokes into 5 primary categories. 1. Large artery atherosclerosis, where stroke is due to significant stenosis or occlusion of a major artery. 2. Cardioembolism, stroke due to emboli from the heart, often associated with conditions such as atrial fibrillation. 3. Small vessel occlusion or lacunar strokes, which result from occlusion of small penetrating arteries, typically seen in hypertension or diabetes. 4. Stroke of other determined etiology, less common causes such as vasculitis, hypercoagulable states, or arterial dissection. And 5. Stroke of undetermined etiology, when no definite cause is identified despite extensive evaluation. For these cryptogenic strokes, it's essential to rule out occult atrial fibrillation and other paroxysmal arrhythmias, often necessitating prolonged monitoring with a loop recorder or an event monitor before discharge. Throughout this diagnostic process, remain vigilant for common pitfalls, such as stroke mimics or missing small but clinically significant infarcts. Moving to management, the window for IV thrombolysis remains at 4.5 hours, but patient selection is key. Mechanical thrombectomy is indicated up to 24 hours for large vessel occlusions, or LVOs. Recent studies support, however, extending thrombectomy to distal M2 occlusions in patients with disabling symptoms like aphasia. Adherence to the guidelines from the AHA/ASA is critical, ensuring that every decision is backed by evidence. Consider the nuances in thrombolytic therapy, especially in those with low NIH stroke scores but significant deficits. In summary, acute ischemic stroke requires a combination of rapid identification, precise diagnostics, and evidence-based management. Your expertise in these areas is crucial for improving patient outcomes. Stay tuned for more targeted insights that will help you refine your practice. Thank you for watching. If you found this video helpful, please like, subscribe, and share with your colleagues. Leave your questions and comments below, and we'll address them in future episodes. Stay updated with Neurobrief for more essential neurology content.